session. I would request the chairperson to please unmute himself and switch on the camera, starting with Dr. Mangat Dogra. Over to you, sir.
Okay, thank you. I don't know if the company people are going to say something before. So if they are, then I would first hand over to them. In case they are not, then I can straight away start with the. So I do see here Pradeep.
So you can start, sir.
So should we start?
Yes, sir.
Good afternoon, sir. Rupak here.
Hi, Rupak. How are you? Good seeing you.
I'm absolutely fine, sir. Absolutely.
Great. That's nice. That's
nice to see you after a long time.
Yes. I think the times are such. We were just now talking about the same. I think we'll go ahead here then with the this scientific session, which is a Bayer scientific session. And it's a very interesting session addressing the patient needs in wet AMD and PCV. And we have quite a list of speakers here, eminent speakers, those who are going to take us through this, as well as we have a panel where Dr. Muna Bhinde and Rupak Kanti Viswas, they are going to be helping us with the panel discussion. I don't see as yet our moderator, Dr. Raja Narayan, but I think we'll be okay if we start with the first speaker, the molecular properties of anti-Vegf agents by Dr. Vinay Garudia. I think that's a very, very important topic. So Vinay is from Delhi, and he's one of the very prominent vitreoretinal person from our capital, and he has long years of experience, and I'm sure he's going to give his pearls of wisdom to us. Vinay, please.
Thank you, sir. I must thank AIOC and Bayer to invite me for this session, and it's a pleasure to meet Dr. Dogra, Dr. Bhinde, and others also. So I think let me start with my presentation. Just a second. Is it visible, sir?
Yes, absolutely.
Yeah. So today we'll be like, I'll straight away jump to the topic of the point for discussion today. We all know that anti-VEGF agents are the mainstay of treatment for AMD, ECV, and many of the vascular pathologies also. Now, what is the relevance of the molecular properties of these anti-VEGF agents in our treatment? Because what we actually want is an agent which is effective and which also has a longer duration of action and which is safe, so that it is more convenient for the patient, so they don't have to visit us again and again, and it is safe and it is effective. So let's go back to our pharmacology and understand that what are the molecular factors that determine how the drug interacts with the body. So first of all is the concentration in which the drug is given. Of course, the higher concentration would have more effect and also more side effects also. And then you have got a charge that kind of decides how much of the permeability is going to be there, how much of absorption is going to be there. Though in case of anti-VEGF, because we are giving intravitreally, that is not a very important factor. The size of the molecule is important because that determines the number of moles that are going to go in a particular dose that you're giving. And also that somehow determines the duration of the action, because the larger molecules are more likely to stay longer than the shorter molecules. The binding affinity is very important because we want to have a molecule which has a high affinity to bind to the target audience, to the target tissue, or to the target molecule. And the potency is that what is the minimum concentration required to actually achieve that effect. So if you've got two drugs, with one with higher potency, a lesser volume or the lesser molar concentration of the drug is going to work rather than the other one which has got a lower potency. So let us see how these factors affect when we talk about the anti-VEGFs. So the important things that are there for anti-VEGFs are the molecular size, the molar concentration, and the binding affinity. Theoretically speaking, we can increase the duration of action by increasing the half-life so that the things get cleared from the vitreous slowly. Or we can increase the dosage, so you give more of it, so it's going to stay there for a longer time. Or you make something which has got a higher binding affinity, so that even if there's a smaller concentration left inside the eye, that still is going to be effective. So basically, there are three ways in which we can increase the duration of action of a drug and minimize the number of injections and increase the duration between the injections. So let us take a hypothetical situation that this is a chart of concentration on the y-axis and the time along the x-axis. And we see that this is the molar concentration we are talking about, not the milligram per ml or something, because it's the number of moles which are important. So there is a particular half-life to a molecule, so that in that time, the concentration becomes half. So this is, say, the half-life. And this is the initial dosage concentration that you have in the beginning. And slowly, as it decays over the period of time, there comes a time when that minimum threshold required to have the positive effect is passed, and the concentration goes below that. That is when the disease may recur again. So that is when we have to kind of think about giving a repeat injection. So this is the VEGF suppression time that you can see. Now, which are the ways in which we can decrease or increase the suppression time? One way is by changing the molecular size. So if the molecular size is larger, generally speaking, it would have a longer half-life. That means the curve is going to be less steep. Whereas if the molecular size is lower, the T-half is going to be lower. So you will have a steeper curve. So if, for example, here you've got another curve which is more steep, you will see that this crosses the threshold much earlier. So the VEGF suppression time is going to be lower if you decrease the molecular size. Similarly, if you increase the binding affinity, so what happens is that the threshold basically from above, it goes down. Because at a lower threshold, at the lower concentration also it is going to be effective. That also, with everything else staying the same, increases the VEGF suppression time. Or if you do other way around, if you decrease the binding affinity, then the threshold will reach earlier, and then you have the VEGF suppression time reduced. So basically, you can do that. And the third option is that you just increase the dose. So you push in more molecules. And of course, because you're pushed in more molecule with the same T-half, with the same threshold, it is going to work for longer time. Or if you reduce the dose, it will work for lesser time. So these are the three ways in which we can modify the duration of action for a new molecule that we're talking about. So let us first of all talk about the binding affinity of the various anti-VEGFs that are available to us. So this is the KD number that basically means the higher the number, the lesser the affinity to bind. So what we find is that bevacizumab has the highest number. So that is got the least affinity, followed by ranibizumab, then brolucizumab. But aflibercept has got a KD value of 0.5 only, which is about 100 times lesser than that of ranibizumab. So that means it has got 100 times more affinity to bind to VEGF. Therefore, it is more likely to be effective at a lower dosage also. Now, as we know, aflibercept works like a VEGF trap. And it basically works by trapping and binding to the VEGF molecules or also to the placental growth factor also. And they have got two binding sites for the VEGF. So therefore, they are almost doubly effective as far as the number of binding sites go. Now, when we compare the common anti-VEGFs that we have, we find that the molecular weight difference is there. The one with the highest molecular weight is Avastin or bevacizumab. After that is aflibercept with 115 kilodalton, and then ranibizumab, and the smallest one is brolucizumab. And correspondingly, if you see, the half-life is also highest for Avastin, very closely followed by aflibercept, and brolucizumab has actually the lowest T-half, right? But still, brolucizumab somehow works for 3 monthly injection. We will come to that why it happens. So, if you see that the molar dosage. Also we look at the affinity. So you look at the affinity of aflibercept is the best amongst the lot. And also the potency is also the best amongst the lot. So you see it's 0.5 is about the affinity for aflibercept, and 18 is the potency, which compared to ranibizumab is also, it's about 100 times better than this. And this is about 2.5 times better the potency than that. So therefore the VEGF suppression time for aflibercept is 71 days. Whereas the next best is 52 days for brolucizumab. So we see that VEGF suppression time is best for aflibercept that we see. Now, what we do talk about is the dosage of brolucizumab compared to aflibercept. There is a brolucizumab, we are giving much higher dosage of 6 milligram. And that, along with the fact that brolucizumab has a lower molecular weight, the molar concentration of aflibercept is 1. Say we take it as a reference 1. ranibizumab is about half, whereas brolucizumab is about 11 to 12 times molar dose compared to aflibercept. So we are pushing in 12 times the number of molecules inside the eye with each dosage. Therefore, of course, we are pushing more drug inside. Now, coming to the binding affinity, as we said, aflibercept has the best binding affinity of the lot, followed by brolucizumab and then ranibizumab. And the potency, again, there's a best potency that we see with aflibercept, then again followed by ranibizumab and then brolucizumab. So if we combine all the factors together, and again, sorry, coming to the half-life, as we said, aflibercept has a half-life of 9 days compared to ranibizumab, which is 7.2, and brolucizumab, which is about 4.4 or 5. So when we combine all these factors, we see that when it comes to molar dosage, brolucizumab has a benefit because you're pushing in more drug inside the eye. But for all the other factors like binding affinity or the potency or the half-life, aflibercept scores over it. So, but there is also another side of the story that if you push in more drug, it is likely to be having more effect, but it is also likely to be having more side effects. So is it a good idea that if I have to actually increase the time duration of the action, I would rather be working on the binding affinity and the half-life rather than pushing in more and more drug, because that might sometimes cause the complications as well. Now, there is a graphical representation of how a model works, that if you give a brolucizumab and aflibercept to two patients, what you realize is on the day one, the concentration of, on the day one, the concentration of brolucizumab is about 11 times more compared to that of aflibercept. So at the beginning, it is at 11 times concentration compared to aflibercept. But what we find that by day 43, both the molar concentration of both the drugs become almost the same. So the benefit that it has goes away by day 43, even though it started with 11 times concentration in the beginning. And we find that by about day 52, the brolucizumab has reached the threshold level, after which the effect kind of goes lesser, and you probably require a repeat injection after that. Whereas in case of aflibercept, this duration goes on till 71 days. So that gives you a good benefit of 19 days over brolucizumab, despite the fact that it starts with 1/11 the dosage, molar dosage of brolucizumab. So you can see that the curve is much less steep for aflibercept compared to brolucizumab. Now, coming to the time between intravitreal injections, as we know, ranibizumab is to be given at a monthly thing, so it's about 36 days. Brolucizumab, as per this model calculation, is about 52 days. And aflibercept has the best anti-VEGF suppression time of 71 days. Now, how does it show in a real life situation? Again, it's a modeling that we do. So what this model shows, the yellow one is for brolucizumab. Initially, when you're giving monthly dosage for 3 dosages, the concentrations are above the threshold. But after that, when you switch over to Q12, you can find that there are sometimes this dosage kind of comes below the threshold level. And plus, there's a huge amount of fluctuation that is happening in the concentration. It goes very high and goes very low. So there's a lot of fluctuation happening there. In contrast, aflibercept with the Q8 dosages after the loading dose maintains the threshold, maintains the concentration above the threshold. So this is, in summary, was the presentation for me. Now, there are some points to ponder. This is a very, very simplified version of the whole situation. But actually speaking, the life is not so simple. The molar concentration of the drug will actually depend upon the molecular weight that you're using for the same milligram that you're injecting, the dose in milligram, the volume of the globe. So maybe if it is a larger eye, or say a high myopia, you will be achieving a lower molar concentration compared to that of a smaller eye, or even the lens status, because as a phakic eye, there might be higher concentration achieved compared to an aphakic eye. So there are multiple variables that are there. And most of the data most of the practice of treat and extend is actually trying to find the ideal condition for that particular patient. Since there are so many variables involved, we cannot have one single cut formula for every patient. You have to give it every 8 months, 8 weeks in one patient, or every 12 weeks in another patient. You have to kind of customize based on how the patient is going to be responding. So the slope depends upon the vitrectomy status or the PVD status, in case there's inflammation, in case there's glaucoma. All these factors may change the half-life. The less steep the curve, the better it is, because we are going to be having a longer half-life. The threshold concentration for effect depends upon the affinity and the potency of the drug, but also may depend upon the genetic makeup of the patient. So because, for different patients, there might be different thresholds. It might not be a very single one formula fits all. The kind of disease, the stage of disease, because during the active stage of disease, you may be requiring a higher concentration, but during the maintenance phase, you may be requiring a lower concentration. And of course, the potency and affinity of the drug is important. And what we have to also think is that there's also going to be an upper limit also beyond which there might be some side effects beginning to happen. So it is not a good idea to keep pushing lot of drug inside the eye just because you want to increase the duration of action. You have to also think about the side effects of it. So what I found very interesting is that brolucizumab came out with a promise that we are going to be coming with a Q12 dosages, but they came with a drug which was having a lower affinity, the lower half-life. The only way they jacked it up was by increasing the molar concentration. And maybe all the complications that we keep hearing about brolucizumab, is it because they're pushing such a high concentration of drug in the first place and the kind of fluctuations that are happening? So the jury is out on that. But somehow I'm quite happy with the kind of the three good factors that aflibercept has taken without going for the higher concentration. And maybe the future is going to be something like a slow release anti-VEGF agent, the way we have Ozurdex. So if we have something which is going to be having a longer half-life and also has a very slow sustained release, we may be looking at a Q6 months or maybe Q1 year also. So I would like to open up this talk for discussions after this.
I think Raja is here now, so he's going to put the questions to the panel. He was having a connectivity problem. So Raja, please go ahead.
Yeah, thank you, Dr. Dogra. I apologize for the connectivity issues. I hope I'm audible. So very
Yes.
nice presentation, Dr. Garudia. I mean, very lucid. You covered everything so nicely. Someone who probably would not understand these issues, you have brought them out very clearly. Now, coming to the point of the molecular weight size differences between, the focus here is between IG and brolucizumab. Let's keep it that way. Does that have anything to do with the inflammation? Because Novartis has looked at all possible variables for inflammation in brolucizumab. They have looked at endotoxins. They have not been of concern. So what do you think is the
I think you have
benefit versus risk ratio we have to see? More molar concentration of brolucizumab, does that have a benefit? Hello?
You have some issue. Sometimes it is very slow, not audible, and other time it goes like a bullet. So,
Oh, really? Okay. No, I was asking Dr. Garudia whether the molar concentration of brolucizumab, because you get more in that small volume, could that be an issue for the immunogenicity for brolucizumab?
Yeah, I think that may be one of the factors. And I was actually very keen to know that when they compared, Novartis compared 3 milligram versus 6 milligram dosages, did they really find any difference? Of course, they had a problem in the efficacy. They did analyze that. But I would like to get the data, whether they found any difference in the side effects in the two groups, the two arms that they had, because that might give us some clue that whether the side effects are happening because of something which is immunogenic, there, of course, the dose would not matter. Or is it the dose dependent thing where the 3 milligram is likely to be having a lower side effects compared to 6 milligram? But unfortunately, we couldn't get the data on that part. So that would be interesting data to have a look at.
I think
Yes.
what
But in the
Raja is
hot air
asking,
in
and I
one-
would like to little bit contribute here. Now with the new Merlin problem, which they have after 3 injection, I think that is where it comes. Perhaps the dose has gone so much in that later on it is causing inflammation. If you give it monthly, that is where the whole problem has started. And that's how probably at this time in US, they have become very conservative, not using it. So I think those maybe it is playing a role because it is happening after 3 injections. So I don't know what is and you nicely presented that data. So I would like to also have opinion of Munna, or maybe we also have a Vura from here from Thailand. She would have a different experience. Munna?
My experience with brolucizumab is
practically medicine. So I think probably I would desist from this question, but yes, definitely we are concerned. And my only question is they both seem to penetrate the pigment epithelium quite well to have effect at sub-RP proliferation. There must be something in common with both of them to get that effect, because both aflibercept and brolucizumab have very good penetration into the pigment epithelium. So for sub-RP proliferation, they both seem to work well. So probably Dr. Garudia can add to that. So such different structures, why they both seem to act well. The inflammation is different, but the efficacy seems to be good for sub-RP patients.
Actually, instinctively, we would believe that the larger molecule like aflibercept is probably not going to penetrate inside that well, but surprisingly it does so. So I think there is probably something to do with the structure of the molecule or something. Something where we started from in Avastin also, because when Novartis was developing Lucentis, they thought that Avastin would not work because of the large molecule. But we all know that Avastin worked pretty well. So I think the size is not the only factor when it comes to penetration. There are other factors also, probably the charge to it and the molecular structure and all.
So Dr. Garudia, in the HAWK trial, when they compared 6 milligram to 6 milligram, 3 milligram and 6 milligram, the vascular occlusions were actually more in the 3 milligram than 6, surprisingly. So it may not have to do anything with the dosage. It might be something to do with the molecule itself.
Yeah, so precisely. There can be two ways that the side effects are happening. As I said, one is if it's an immunogenic kind of a thing, then the dose would not matter. But there might be some dose-dependent side effects also. So but again, only a single study, we can't really judge it on that. Unfortunately, brolucizumab is not being used too much nowadays. So therefore, we won't have too much of real-world data coming out from that. But it would be interesting to know that one would be the vascular blockage, which is likely to be immunogenic thing, which is not dose-dependent. But we may be getting some other side effects, which probably we have to keep a watch on.
But Dr. Borse, one point which we would like to consider is, while inflammation has been a factor for brolucizumab, the smaller molecule has been shown to penetrate much more. While Dr. Garudia mentioned even bevacizumab did penetrate, even though they never thought it would. But the concentration definitely is more in the subretinal space in brolucizumab, and that's how the PED reduction is also more we have seen with brolucizumab. So that way, in resistant cases, it might still be useful, but inflammation probably is now a big challenge for brolucizumab. Any comments from you, Rupa?
Yeah, I just wanted to bring one more point here. The more concentration of the drug, which is associated with surfactant concentration, also you are pushing it more. So whether it has some effect on that part also, probably.
One other question I had, Dr. Raja. I mean, since we know that higher concentration is kind of working, what if in a resistant case we give it Q2 weeks aflibercept rather than giving brolucizumab, because we are going to increase the dosage by 2 times maybe, and maybe shorter interval between the loading doses might work there. I mean, has anyone tried that? That in a resistant case, instead of 4 weekly, give it 2 weekly aflibercept.
No, I don't know. Maybe Dr. Mona could chip in because it's about aflibercept. In the sense, I have not given aflibercept 2 weeks in resistant cases. That's something which we'll have to see. But I have not tried.
No, I haven't tried, but if at all I've combined it with a steroid, I haven't reduced.
Yeah, that's a good point.
Yeah, I'm a little concerned about shortening the duration for aflibercept, because we do know it has its share of inflammation in the early days. So I would be a little concerned of shortening the duration. But combining with steroids, I would be.
Yeah, we have found good results when we combine it with Ozurdex or steroids, anti-Vegf in resistant cases. We have to, reduce the duration between the injections. That's a good point. So, are there any other questions, Dr. Dogra?
So you're muted, sir.
Yes.
Dr. Dogra, you're muted, sir.
Sorry. We'll have a discussion on similar lines later also. So I think I'm going to invite our guest here, Dr. Vorapon. She's from Thailand. I didn't get your entire sort of CV with me to introduce you. So, but we are looking forward to your talk and you talking on a very interesting subject of like PCV, non-ICGA diagnostic criteria and management. I think this is going to be most useful for everybody because the ICG is not with many people in our country also. So, Dr. Borap.
So Dr.
Thank you very
if I
much.
could just
And
add here, she has published one in American Journal of Ophthalmology, a very important paper. We would like to definitely hear from Dr. Vorapon about that.
Thank you. So it's my great pleasure to join the AIOS meeting this year. And thank you very much for Bayer and the organizing committee for your kind invitation. So we all know that ICGA or indocyanine green angiography has been the gold standard to diagnose PCV. However, ICGA has several limitations. It is invasive, time-consuming, and most importantly, ICGA is not always available at our retinal centers. For example, in Thailand, more than half of the retinal centers across the country do not have ICGA. So when PCV have higher prevalence in our Asian populations, but we do not have ICGA available, how can we manage these cases without ICGA? Actually, there are alternative imaging modalities that can help to diagnose PCV. And today I would like to focus on the use of color fundus photography and OCT, which I believe these tools are available in most clinics and really helpful for PCV diagnosis. Here are the characteristics on fundus examination that suggesting the diagnosis of PCV, including the presence of subretinal orange nodules, fibrovascular pigment epithelial detachment, the presence of massive subretinal hemorrhage, peripapillary location of the lesion, and no large drusen in the fellow eye. So if your patient presented with submacular hemorrhage in one eye, but the fellow eye have no large drusen, it is unlikely to be AMD, because if the patient have submacular hemorrhage due to neovascular AMD or advanced AMD, the fellow eye should have at least the early stage or the presence of drusen. So if the fellow eye doesn't have any drusen, then you should think about the cause by PCV or some other diseases, not AMD. And here are the characteristics of PCV on spectral domain OCT, including the signs of polypoidal lesion, sharp peaked PED, hyperreflective ring underneath the PED, and notch PED on the top surface of the PED. Also, double layer side or the thin separation between the RPE and Brooks membrane, suggesting the signs of branching vascular network or BVN. However, double layer side can also found in other diseases like CSC or type 1 CNV as well. In some cases, you can see the thick choroid, but not always. Now let's take a look at a case example. A 77-year-old Thai man presented with submacular hemorrhage in the right, and the left eye show unremarkable findings without any large drusen. OCT across the lesion show multiple notch PED with hyperreflective ring inside, so we suspect the PCV diagnosis. And later, ICGA confirms the polypoidal lesions. So it seems possible to diagnose PCV even without ICGA. So at that time in 2014, we did some literature review and found very few studies, and this study focusing on the use of OCT features only. However, in clinical practice, in addition to the OCT information, we typically have information from fundus examination, and sometimes we have FFA. So we conducted this study to evaluate the sensitivity and specificity of features on color fundus picture, OCT, and FFA. to diagnose PCV without ICG angiography. And this paper already published in JAMA Ophthalmology in 2019. And we come up with these 4 criteria. And from this study, actually, we evaluate all the features from fundus examination that I described earlier, as well as several signs on OCT, and also the findings from FFA, whether they have classic or CalCNV or some other findings. However, the 4 best features that can identify PCV were these 4 signs, including the notch or hemorrhagic PED on color fundus, sharp peak PED, PED notch, and hyperreflective ring on spectral domain OCT. And if you found at least 2 or 4 features, you will reach 95% sensitivity, 95% specificity, and 93% accuracy for PCV diagnosis. Now, let me walk you through each of these features. So feature number 1 is the notch or hemorrhagic PED. So you can see the fibrovascular PED like these 2. And sometimes they have hemorrhage inside. So you can see the bleeding level inside the PED like these 2. And all 4 eyes met the criteria. Number 2 is sharply peaked PED. And this term, previously, there was no literature provide a clear definition of this term. So in this study, we define as the PED with the border between 70 to 90 degrees, and how we evaluate the angle, we just eyeballing, look at the border of the PED in each scan. If one of the scan showing the angle between 70 to 90 degrees, like all 3 lesions, you can meet the criteria. And number 3 is PED notch or multilobulated PED. You can see 1, 2, 3 notches. It doesn't matter if you found only 1 notch, it counts for this one. And number 4 is hyperreflective ring underneath the PED. So the ring sometimes large like this one, sometimes it's smaller, and sometimes it's very tiny. So this one is actually the most difficult feature, but you have to learn. And if you start looking for the sign, you will be more familiar and be able to identify. If you are not sure, don't worry. You just look at the other features instead. But if you found these ring features, you can count as another criteria. So remember that we no need to find all 4 features, but you need only at least 2 features to diagnose PCV. Now let's take a look at the case example. This case presented with blurry vision in the right. We can see serous maculopathy with fibrovascular PED. So how many features can you see for this case? So I saw sharply peaked PED on OCT, as well as hyperreflective ring and double layer sign. So this case, we can count 3 criteria. So we can suggest PCV diagnosis, and later ICGA confirm the polypoidal lesions. Here's another case. This patient actually presented for diabetic retinopathy screening, but we saw subretinal hemorrhage and also PED next to the optic disc. So we performed OCT and we found subretinal fluid as well as fibrovascular PED. In this case, we saw the hyperreflective ring and also PED notch. So we found 2 criteria and suggesting PCV diagnosis. So we sent the patients to underwent ICG angiography. And here's the video angiography. You can see the pulsatile polypoidal lesions, and this can confirm PCV diagnosis based on the Everest criteria. But actually, we can tell by our OCT and fundus picture before this. And now the last case, a patient presented with massive subretinal hemorrhage in the left. The right eye showed unremarkable findings. So we got the first criteria, hemorrhagic PED. And OCT across the lesion showing double layer sign, sharp peak PED and notch PED. Again, this case matched 3 criteria, and later ICGA confirmed PCV diagnosis. And here are the 4 features that can help you identify PCV, and I hope it is helpful for your clinical practice. And from my experience, actually PCV can present with various presentation, but we can roughly classify into 2 types. The first one will be polypoidal lesions with leakage. So you can find subretinal fluid with single or multiple sharply peaked PED like this one. And sometimes the polypoidal lesion can be ruptured with subretinal hemorrhage, and then you can see the PED notch or multilobulated PED like this one. And we published this criteria in 2019, and recently in 2021, the Asia Pacific Ocular Imaging Society PCV work group also proposed the non-ICGA diagnostic criteria to diagnose PCV without ICGA. They proposed that if there were 3 OCT criteria, they will have accuracy of 90% for PCV diagnosis. And the 3 criteria, including sub-RPE ring-like lesion, sharp peaked PED, and the on-fast OCT complex RVE elevation. And for on-fast OCT features, you can see like this green box, and you can find on-fast OCT image if you have size, spectralist domain OCT, or any OCTA machine. And now let's move to the role of OCTA, because I believe many of you have OCTA in your clinic right now. However, OCTA have promising ability to detect BVN comparing to ICGA, but it has inferior ability in detecting polypoidal lesion due to the slow flow of the red blood cell movement inside the polyp. And so therefore, OCTA is not that helpful for PCV. So my recommendation is, if you have OCTA machine, you can use your knowledge by looking at suggestive features from fundus picture and also structural OCT and combine all the information together. For example, in this case, you can see the suspect branching vascular network on OCTA. So if you look at the structure OCT at the bottom, you can see the double layer sign. Also here, if you suspect polypoidal lesion in this area and you look at the structural OCT, so you can move the cursor to the suspect area and you can see sharp peak PED, so it can suggest the polypoidal lesion. And this case, ICG also confirmed PCV diagnosis. And this case is a nice presentation that on ICGA, you can see polypoidal lesion better, while the OCTA can show branching vascular network better visualized on OCTA. Here's another case, a patient presented with blurry vision in the right. We found fibrobascular PED from fundus examination. OCT show double layer sign and also sharp peaked PED. So this case matched 2 criteria and we think about PCV. We sent the patients to perform OCTA, and here we saw the suspect branching vascular network and polypoidal lesion. And then we evaluate the structural OCT altogether by moving the cursor to the BVN area, and we saw double layer sign. When we move the cursor to suspect polypoidal lesion area, we saw the sharp peaked PED. And later, ICGA confirms the PCV diagnosis. So this case actually show a nice presentation of OCTA finding, but actually from my clinic, I think many cases, the OCTA quality is not good enough and it's quite difficult to diagnose PCV using OCTA alone. In summary, for part 1, I think ICGA remains the gold standard to diagnose PCV, but if ICGA is not available in your clinic, the suggestive features from fundus examination and OCT can provide high accuracy for PCV diagnosis without ICGA. Now let's move to the treatment. And today I'd like to review briefly the results of PLANET study year 2 with you. And here's the PLANET study, which is the randomized control trial evaluating the safety and efficacy of aflibercept monotherapy versus aflibercept plus rescue PDT. Each participant from the PLANET study will receive 3 monthly loading injections, and then at week 12, each participant will be randomized into 2 arms to receive aflibercept Q8 week monotherapy or aflibercept Q8 week plus rescue PDT. And at the end of year 1, the patient will have optional treat and extend treatment based on the physician's decision. So the 2-year results showing that right after the first 3 injections, you can see visual improvement in both arms and remains approximately 10 letter improvement on average in year 1, which remains the same level through 2 years. And for the second year, the patients can have optional treat and extend dosing. So the mean injection number can be decreased from 8.1 to 4.6 injection, while visual acuity can remain excellent. Regarding the role of rescue PDT, they found that in both arms, less than 18% of the patients require rescue PDT treatment. And how many of them can remain treatment interval for 12 weeks or longer? They found that at 2 years, 40% of the patients can have injection intervals of 12 weeks or longer. And what about the visual acuity of these patients? They found that either the patient who can extend to 10 weeks or longer or 12 weeks or longer can maintain excellent visual improvement more than 10 letter through 2 years in both groups. In summary, from PLANET study, it confirms the efficacy of aflibercept monotherapy, which is non-inferior to aflibercept with rescue PDT. And more than 80% of the patient does not require rescue PDT. 40% of the patients can have injection interval of 12 weeks or longer without visual deterioration. In addition to visual outcome, we know that for PCV, complete polypoidal regression also another important anatomical outcome because it related to the recurrence rate in PCV. And we learned that aflibercept monotherapy can result in complete polypoidal regression without PDT in a majority of many patients. However, the exact timing when complete regression occurs after the first dose of aflibercept injection is unknown. So today I'd like to share the results from our study in Thailand. And this one, we evaluate the timing of complete polyp regression following aflibercept treatment in PCV in Thai patients. And this study recently published several months ago in Ophthalmology Retina. So the primary objective is to evaluate the timing of complete polyp regression on ICGA after aflibercept treatment in PCV. This was a 1-year prospective case series, including 40 eyes with newly diagnosed PCV, and we conducted the study in 2 study sites in Thailand. Each patient will receive underwent simultaneous FA and ICG testing at baseline and then repeat every 2 months until 1 year. For treatment regimen, we start with 3 loading injections and then every 8 weeks. But if the patient have persistent subretinal fluid on OCT, they can have the injection as often as monthly. But if the persistent subretinal fluid persists through 6 monthly injections, then we can perform rescue PDT. Results from 40 eyes, we found that 90% of them have 5 polypoidal lesions or more. And mean injection number was 8.5 in the first year. 5% need additional PDT and 80% of them remains inactive on OCT. Regarding the rate of polyp regression, 55% have complete regression, 40% have partial regression, and 5% have persistent polyp. Now we're gonna focus on the 22 eyes that have complete polyp regression at 1 year. And we traced back and found that 50% of them who have complete regression at 1 year already have complete regression at month 2 or right after 2 doses of aflibercept injection. And on average, the median duration was 3 months for complete regression. Interquartile range 2 to 6 months, it means that for eyes that have complete regression at 1 year, most of them already have complete regression within the first 6 months. We also evaluate the visual improvement, and the vision improved from 2125 to 2060 on average. And also VFQ-25 or quality of life score improved from 80 to 93 at 1 year. And here's a case example presented with PCV at baseline, have well response after aflibercept monotherapy. And here you can see the ICGA show complete absence of polypoidal lesion at month 2 or right after the first 2 injections of aflibercept. And in summary, this study suggested that 55% of the study eyes have complete regression at 1 year, and a majority of them have complete regression within 6 months. And these findings support consideration of aflibercept for PCV to achieve both anatomical and visual outcome. Thank you very much.
Thank you, Dr. Borappan. That was an excellent presentation. Elucidating all the points of PCV which are of practical importance to a general medical retina specialist. I will come back to you with questions. First, I will go to the panelists. Rupak, do you routinely do ICG in your patients, or do you rely on OCT or OCT angiography?
No, Raja, actually, this is a thought process long back we had. And we strongly believe that these are the criteria we can diagnose PCV even without ICG. But as I am having the problem is that if you are planning for, now the PDT is not available, and most of the extrafoveal PCV we plan for the focal laser. So if we need to plan for focal laser, then we have to plan for ICG. Otherwise, for diagnosing and for anti-VEGF monotherapy, I think we can go with this criteria quite safely, and we will land up of good result.
I think you have made an important, given that PDT is not available enough, not having ICG, is going to go with injections. But
Okay.
do you start with ranibizumab or do you give aflibercept? Rupak, do you give ranibizumab or aflibercept?
No, I once the diagnosis of PCV is there, I straight away go for aflibercept.
Okay, good.
Because the ranibizumab does not cause that much of PCV regression.
Yeah, thanks, Rupak. Dr. Dogra, you have any question?
I have a question for Borappan. The question is, have they gone beyond? Well, you saw that there was a 50% complete regression. What about recurrence in these 50% later on? Because recurrence is also known to occur even after PDT. So late stage, have you gone to a stage beyond this?
Yeah, so it's very interesting question. So actually, we also have another study follow up on the long-term results. And we found that most eyes that show complete regression after 1 year of treatment remains inactive, while those who have partially regressed or incomplete regress, and then if we stop treatment after 1 year, it has possibility to reoccur. So I think it's important that if you want to stop treatment, you have to make sure that it complete regress. Otherwise, you have to close follow up for recurrence. What about your experience?
I think absolutely. I think that is what is very important for us also to know if we have, because sometimes the recurrences could happen even later on with after following PDT also. So I think that kind of a long-term sort of results, if they are published from both sides, I think that would be very useful for everyone. Yes. Dr. Munna, what is your take?
Yeah. We haven't looked at the time to disappearance of the polyp, but one thing I've noticed, especially in older people, the branching vascular network seems to grow, and then you may sometimes find a polyp very distant from where the original lesion started. And this can happen a few years later. So this is something that I have noticed at that point. Then I would do an ICG to see where exactly the vascular network is starting from. And we find it's the origin, but the branches have grown so long, you find them above the disc, sometimes even nasal to the disc. So sometimes that is something that I have noticed in my patients.
Yeah, that's a very important point Dr. Muna has raised. When you are looking at recurrence of polyps may take some time, in fact, many years, but there may be other signs of early recurrence. Whether we treat them or we just wait for the exudation to come is a debate. But one of the early signs on OCT is the increase in thickness of the double layer sign or the enlargement of the sign of the double layer between the RP and Brooks, even before there is a recurrence of polyp. So whereupon, do you look at these features of the double layer sign either increasing in thickness or their area and then start treating them even if there is no fluid, or do you wait for the fluid to come back?
So for me, I typically wait until the fluids comes back because I totally agree with Dr. Muna that after the treatment, the BVN persists. And what I found is it's still difficult to predict what are the factors because many patients have BVN but remains inactive. But in some eyes, they have remaining BVN and one day the fluid comes back. So basically, I just periodically follow up with no treatment, and then I start treatment when the exudation comes back.
Great.
Yes.
So, Dr. Mona, again, a question for you. Is it necessary to see all the polyps? Because we know that if you do an OCT or an OCTA, while the BVN is very nicely picked up by OCTA, but you may miss some of the polyps. Is it necessary to see all the polyps, which means that you would have to do ICG in all cases? Or do you think it's not required to see all the polyps? You can start with monotherapy, and then later on, if there is a recurrence, you want to do an ICG. What's your protocol?
I would love to see all the polyps. And with OCTA, now this wet source OCTA, we are able to see most of them. And if you do an OCT, you can do a 360-degree radial scan, which will pick up polyps in all quadrants, making sure you've got the entire network in your capture. And a fundus photograph also will give a clue. But I would always like to know approximately where I'm headed when I'm starting off, so that I have a clear idea what I can tell the patient.
And do you consider if PDT is not there now, but when PDT was available, were you considering at baseline or if there was recurrence of PCV?
Probably before the Planet results came, I was looking at probably combination of low fluence with ranibizumab. But now we have the option of aflibercept, so my indications for primary PDT, even if they were there, would be very low.
Great. Are there any other questions?
Yes,
Dr.
anybody?
Dogra?
Any other from anyone else here would like
just to ask Dr. Borapan, is it what is your systemic association, like hypertension or any other systemic association? Do you think is it associated with PCV or the recurrence?
Yeah, I try to find the factor, but I fail. I mean, I cannot see the significant difference yet.
Okay.
So if we have nothing else here, then we can go on to our next talk on Treat and Extend by Dr. Nishikant Borse from Mumbai. And so Dr. Nishikant, please.
Thank you very much, sir. So I'll be talking on the Treat and Extend, and we'll be touching on the entire study, the 2-year outcome, and let's see what we have to do with the Treat and Extend. This is the standard disclaimer since it's a sponsored thing, and I thank Bayer for this lovely symposium and AIOC, of course, to allow us to speak on this forum. So when we look at our treatment regimes for no, for neovascular AMD, that basically we can classify them into two. One is either a proactive type or a reactive. A proactive being a fixed dosing, which was like monthly, which were given initially in the trials, or the treat and extend that we do. And reactive is the PRN or the treat to target like things. Now, basically what it means is in proactive, we go ahead and treat it before the disease can recur. Whereas in reactive, it's like a reaction to the fluid or the disease after it has come back. Now, we all will agree that the fundamental principles that we would like for every treatment for our patients is to have the maximum benefits and maintain the visual acuity, and maintaining the visual acuity with best possible intervals between the two injections so that we reduce the burden for the patient. And we should be able to prognosticate when we can treat next so that the patient is well aware when he's going to come back for the next injection, rather than in a PRN when it many times comes as a surprise to the patient that, yo, you got a fluid today, you got to take an injection. And then we just don't know. We can ask them to keep on coming every month, and then if the fluid is there, we treat, and if the fluid is not there, we don't treat. So it's sort of an uncertain thing for the patient. So it's always better to give them a certain sort of a schedule for their injections. And if we can combine the treatment and monitoring, then it will be the best, because it will actually reduce the number of visits the patient has. And these four principles together would make up the proactive treatment. So now proactive treat and extend regimen is sort of a combination that has been done between the monthly and the PRN sort of a regime, so that we give the best possible visual acuity to the patients and the least amount of injections. So the main aim is to minimize the risk of the disease recurrence, and rather than responding to it after its recurrence like we do it in PRN. So now what is treat and extend? Basically what we do is go on giving 3 monthly dose and then continue treating it that way till the time the AMD becomes dry. And then you continue to treat the dry retina at each visit with a gradual extension of time, which can be either 2 or 4 weekly extension, depending on the patient's characteristics and your comfort, until the AMD becomes alive or active. And if it becomes active, then you shorten the duration back. Let's take an indicative case here. There's an active CNVM, and after 3 months of loading doses, it is still active. So you continue giving injections till the time the activity goes off. And once the activity goes off and we have reached a dry state, now then we can think of extending the dosage and calling the patient back after 10 weeks. And the patient comes back after 10 weeks. And when you see the patient after 10 weeks, you still find it to be dry. So you go on saying that, okay, you come now back after 12 weeks. But if the patient comes back after 12 weeks and you find some amount of activity, then you reduce the injection interval to 10 weeks now. You call the patient back after 10 weeks. Now, as per every individual and as per every treating doctor, you can decide what is the maximum fluid interval. And most of the times, people like to have the maximum fluid interval at 10 weeks. Means if there is a fluid, we should not be extending it more than 10 weeks beyond. Let's take a clinical case, another one. This is one 70-year-old gentleman who came to us with wet AMD or query PCV type of a picture. And after the loading doses, you can see the RPED and the fluid settling down very well. And then since the fluid was just minimal, I sort of shifted him to 8 weekly injections. And at 8 weekly injections, you can see that the lesion is very stable. And then I extend it to 10 weekly injections. And then the lesion remains dry. So I go on extending it to 12 weekly. The lesion still remains dry. And then I decide to extend it further to 16 weekly. And now he's maintaining on a 16 weekly injections, which comes to nearly like once in 4 months. So it's about 3 injections per year, and is maintaining a vision of about 6/9. I think is fantastic for a lesion which started off with something like this. So with treat and extend, we can actually give the maximum visual acuity benefit with minimal injections. And it has been proven in RCTs, which we have been seeing for the last so many years. Like for example, if you see View 1 and View 2 study, if you see the View 2 extension study, you will find that up to 50% of the patients who got aflibercept 2 milligrams, which was supposed to be Q8, but they could be maintained by extending the injections up to 12 weeks. So in view 2 itself, it was clear that about 50% of the patients could be maintained at 12 weekly dosing in year 2. So this was in the randomized control trial. Even if you see the PLANET study, which was for PCV, even here we could find that the vision gains could be maintained with an optional treat and extend in the year 2. Now, a view 1 extension study, which is, I think, a slightly controversial thing because the dosing regimen was abruptly changed from Q12 to Q8 because the FDA approval came in the middle of it. But in that study, if you see, we can see that treat and extend has given a good amount of stability to the visual acuity gains that were achieved in the first year or the second year itself. So what would be the current posology that we would like to follow? It would be like initial 3 months dosing, then shift over to fixed 8 monthly dosing, like I showed before, until the time the lesion becomes totally dry. And once it is dry, then we can actually go ahead with a proactive treat and extend dosing that I have discussed before, rather than continue with the fixed Q&A, Q8 doses that we have said. Now, what is the importance of treat and extend? It is a fantastic regimen because, like I said, it gives you a good amount of functional outcomes for the patient. The most important thing is we can offer the patient an individualized treatment, because we usually come to know that this patient is going to need 8 monthly or 12 monthly injection by the end of the first year itself. So we can actually give the patient a clear-cut picture as to roadmap as to when they are supposed to come next and supposed to see us. And this type of an approach avoids both over treatment and under treatment, and thereby it gives us a good amount of functional and anatomical outcome. So since the patient also receives the injection along with the monitoring, the number of visits are absolutely less. And that's why we can have a good amount of visual acuity gain, and we can also have the patient compliance maintained because we have given them a clear roadmap and an uncertain sort of a thing. We have seen that it works well in RCTs, but in real world studies also, we have seen that the treat and extend regimen have been useful in maintaining the visual acuity gains with minimum amount of injections. Now, there are 1 or 2 studies which I would like to cite. One is this fantastic study by Epstein et al., which actually showed that the visual acuity gains not only could be maintained, but it could actually be even increased in the second year when you go to treat and extend. And there's a lovely paper from the Moorefields group, which shows the same thing, that after the year 1, we can actually maintain, not only maintain, we can actually slightly even improve the visual acuity gain with the treat and extend regimen. But for that, they have devised something called as a Moorefields Protocol, which I would definitely like to share with you because it's really good and it can be replicated in our day-to-day practice. So what they do is they give aflibercept at the week 4, 8, and 16, that is the loading dose, and then give 8 weekly at week 24 and 32. And at week 40, they decide what to do. At week 40, if they find that the CNVM activity is actually increasing, they intensify the treatment and then reduce the interval by 2 weeks to maybe 6 weeks. And then even if it is increasing, then they can even reduce the weeks further to 4 weeks. If the CNVM activity is just persistent or just a bit, then you can continue with 8 weekly treatment till the time it dries off. And if you find that the CNVM is inactive, you can go on increasing the treatment interval to 10 weeks. And if they still find that the CNVM is inactive, then you can increase it to 12 weeks. So this sort of a protocol, if we can calculate for our patients and give them a clear roadmap, I'm sure the patient compliance becomes much more, and we can get a maximum amount of results from treat and extend, as shown by Hosokawa et al., which have shown the excellent visual outcomes that can be achieved and even maintained over 3 years with a proactive treat and extend dosing. In this particular study, the patients gained more than 8 letters in the maintenance with treat and extend. And if you can see, the number of injections go on reducing from about 8.3 to 6 to about 5.8 in the 3rd year. So we know that treat and extend works very well, and we know that it is a good sort of regimen to. but we were not sure how actually to go ahead and practice it, whether we should increase it by 2 weeks or whether we should increase it by 4 weeks. And that's where a study called Altair study was done. It was a phase 4 study designed to evaluate the efficacy of aflibercept into different treat and extend regimens. So it was a treat and extend regimen which was designed into 2 different groups. What they did here is that the patients were initially given 3 loading doses at monthly injections. And at week 16, the patients were randomized 1:1 into 2 groups. In one group, the treat and extend was practiced with a week interval extension of every 2 weeks allowed, like 8 to 10, 10 to 12, and 12 to 14, and so on and so forth. Whereas in the other group, they said you can have the interval adjusted straight to 4 weeks rather than 2 weeks. So you can go from 8 weekly to 12, 12 to 16. And at week 52, there was a primary endpoint to see what amount of baseline BCVA gain that was seen in this particular patient. And the study was going to be continued to week 96. This is again just the study design in a more picturized way for us to know how the Altair study was designed. These were the patient characteristics. But more importantly to know is what were the criteria used for either extension or shortening the duration or maintaining the duration. Let's see the extension duration. The extension was very clear. If there is no fluid loss or there is no increase in the loss of vision or there is no increase in the CRT of more than 100 microns, let's make it that easy. And of course, you should not see any activity of CNVM. Vice versa, if you saw new fluid or you saw there was more loss of visual acuity, or if the macular thickness increased by more than 100 microns, or if you saw new vascularization, then of course you shortened the duration. But if you find that residual but decreased fluid, then you can say that let's continue with the same or maintain with the same dosage that the patient is going on. Now you have to understand that the minimum interval was 8 weeks and maximum allowed was 16 weeks for these patients. Now let's see what the results came in. When you saw both the groups, whether it was a 2-week or a 4-week adjustment, at first year, there were similar visual acuity gains of about roughly 8.5 to 9 letters. But when you go to the second year, we can find that the visual acuity gains were slightly more in favor of the 2-weekly adjustment as compared to the 9-weekly. However, even if you take both the groups together, there were good visual acuity gains which can be maintained at the second year itself or up to week 96 itself. Now, what was the last week interval, that injection interval that we could have up to a final visit of week 96? In a 2-week group, it was a mean of 12.2 plus or minus 3.6. And even in the 4-week group, it was the same, which is about 12.5 plus or minus 3.6 weeks. The patients who could be extended beyond 12 weeks were also about 55 to 60% in both the groups. So basically what it tells is, whichever way you do it, you can extend it more by either 2-weekly or 4-weekly. Whichever way you can extend the dosing by treat and extend. And that's what has been proven by Altair group. Now, up to 96% of the patients who reached the maximum possible treatment interval, that is up to 16 weeks that we said, were maintained up to week 96 in a 2-week adjustment group. And that's why, again, I would say that the Altair study slightly favors the 2-week adjustment more than the 4-week adjustment. Number one is number of patients who could be extended to 16 weeks were more with 2 weeks, and even the visual acuity gains were slightly more in favor of the 2-week interval extension as compared to the 4-week extension group that we had. So in conclusion, we know that the intravitreal aflibercept administered in naive patients with exudative AMD using 2 different type of treat and extend regimen, both work extremely well, and both of them give a good amount of visual acuity improvement and anatomic improvement with extension of the dosage possible and minimizing the treatment burden on the patients. And as we go and have more and more practical experience into treat and extend, I think we will be able to give the patient the best functional and anatomical outcomes by increasing the injection intervals and reducing the burden. So in conclusion, the effectiveness of treat and extend has been given a lot of emphasis and has been proven to be useful in multiple studies. You can see the ARIES studies where about approximately 50% of the patients in both groups maintained for more than 12 weeks up to week 104. Like we have seen in Altair study, we have seen up to 40% of the patients can be maintained at intervals up to 16 weeks by week 96. Even in the Japanese study, it showed the effectivity of the Altair study, of the treat and extend regimen, sorry. So in conclusion, this is just to show that the treat and extend regimen does work. This is the same case again. And if we practice the regimen, which I like was of the Moorefields group, I think we can give the best of the visual acuity gains for our patients with the least amount of injections and least amount of visits to the clinic, thereby improving the patient compliance. Thank you.
Thank you so much, Dr. Nishikant. It was a wonderful presentation talking about treat and extend, how we should use that carefully in our patients with AMD. I saw in your last case, again, the last slide, which you had showed earlier in your presentation, that there was, you had extended even when there was some amount of subretinal fluid in the middle row you had shown. I was wondering if you tolerate some amount of subretinal fluid, like the fluid study criteria. If yes, how do you decide to extend in those patients, even when they have subretinal fluid?
Yeah, so if there is no intraretinal fluid and we just have subretinal fluid, I do tolerate some amount of subretinal fluid as per the fluid study. But of course, I maintain that the patient has to be injected. The patient should not be off the treatment. The patient has to come back for a treatment at 10 weekly or 12 weekly interval. So I do tolerate some amount of subretinal fluid, yes.
That's good to hear, because the next question for you, Dr. Bose, is I know you have used brolucizumab quite a bit. Do you treat and extend with brolucizumab too, in the sense when the patients are 3 monthly dosing, do you extend beyond 3 months as treat and extend for brolucizumab?
Yeah, so Raja, since we have started using brolucizumab just since about October and November, it's just about 6-7 months. So it's very difficult for us to comment how the treat and extend regimen is going to work out over the long period. But yes, the initial patients of mine who were naive cases, I have been able to extend the dosing from first 8 weekly and then to 16 weeks also in one particular case.
I think Raja
Yeah. So
has
since
muted.
brolucizumab has known to have a slightly longer duration of action, I think the dosing itself becomes more apart than the other injections. So even you can.
Thank you so much. Ask Rupak right now, when the OCT.
No, Raja, you are not audible.
Go ahead, Dr. Dogra.
Yes, I think there's another connection problem here. I just wanted to, before Raja is going to come back and put a question to Rupak, I'm going to ask Vorapon, what is the status of using brolucizumab in Thailand?
I'm talking.
So in Thailand, brolucizumab was just approved by the Thai FDA, I think last month. So the usage is quite limited because after it was approved by government, it has to be approved from the local hospital. Yeah, for example, in my hospital, it was not approved yet. So I don't have the real experience to use brolucizumab.
Okay.
Thank you so much. Actually, sorry for the poor connection. Dr. Dogra, you and I always have similar thoughts, for what you asked earlier, a similar question I have for her. In fact, I was going to ask, does government insurance work for all patients in Thailand, or is it for a select group of patients? And what's the protocol that is approved? Does the government reimburse, treat and extend, or PRN? How does it work?
You mean for all anti-VEGF agents, right?
Yes.
So actually, Avastin will be the first line injections for the Thai citizen, that because it's like the Ministry of Health approved Avastin as the one official drug that everyone can get for free. So anyone can get Avastin for free, but for those who can have aflibercept or Lucentis or maybe brolucizumab in the future will be the one who have insurance, or maybe they work for the government. They will have like another step, like the better coverage. Yeah, so not like 30% of the people in Thailand can get Lucentis or aflibercept or brolucizumab for free, but the rest they have to pay by themselves.
That's good to know. So, Dr. Mona, if you have a patient who is, let's say you start with Avastin, and if the patient doesn't respond, when do you look at switching those patients to another anti-VEGF? How do you decide which one to choose? And when do you decide to use steroids along with anti-VEGF?
Generally, I would go after the loading dose of 3. I would give 3 loading doses unless the response is dramatic either way. And then I would probably look at 2 consecutive injections where there has been no change, or if it's getting worse. I may choose to re-image them before I switch. And switching from Avastin, I would go to I would start with ranibizumab with the option of the biosimilar if they can't afford ranibizumab. But if I was to start with ranibizumab, maybe I would switch to aflibercept. But before switching, I would image and I would do OCT angiogram to see whether there has been any change in the neovascular network compared to the activity I would see on OCT. So that's how I would proceed. And steroids, my usage is very limited. For very large lesions which are resistant to even aflibercept, sometimes I may combine with steroids.
Thank you, ma'am. In terms of decision for injecting steroids, do you look at large PEDs or any amount of cutoff of thickness? How do you decide using steroids?
You're asking me, Raja?
So is there any cutoff thickness for PEDs or fluid level?
In the PED, I would be looking at the presence of intraretinal fluid, because we know that sometimes those cysts don't go away for a long time, but they go away very rapidly with steroid. So I would think those cysts are the ones I want to get rid of. If everything is remaining, then maybe the steroid alone will not work. But if everything else is okay, but cysts are persisting, then I would think of going with steroid.
Thank you, ma'am. Rupak, I had one question for you.
Yes.
I know in India, most of our patients pay out of pocket, they pay cash. Many of them don't have any state insurance or private insurance. And it's a difficult thing to tell a patient to get injection when the OCT is dry. So when we talk about treat and extend, while it's good for ideal situations or in insured conditions, how do you manage your patients, let's say in the second year or third year, they're dry, you still inject or you don't inject? If not, then how often do you follow them up?
See, the situation is like this. The majority of the treat and extend as of now, we do not, as a primary treatment, we don't go for that. So suppose if you given the loading dose, and then the patient has a recurrence, and every time, maybe after 2 months, 3 months, they have a recurrence, and they come, and then you do a PRN basis. So later on, they understand that my disease is a process which needs a longer duration of the treatment. So at that point of time, if you explain them that yes, it is needed, and it is better before the fluid comes, and then you treat, your vision remains better. So that is probably the main point by which you can convince them, and they usually try to follow that, because anyway they are another 3-4 months they need to have a treatment. So it is better that if we can extend it and follow the treat and extend treatment. So the convincing factor is there the disease per se, disease disease pattern per se is actually convincing them.
All right. I think if there is any last minute pressing question, maybe somebody can ask that. Otherwise, I'm going to conclude all the talks here. I think we had a great session, I must say. A lot of things were discussed, and Dr. Vinay Garudia talked about the molecular properties of the anti-VEGFs. I think his talk was so well prepared that he made us all understand about all things about the binding affinity as well as half life, and how the particular dosage of the drug makes a difference. I think it was a great talk, and how the various drugs, they finally will have a duration of action. So Vinay, thank you very much for that. And I think it helps all of us, which we don't even look at so seriously. And our special thanks are to Dr. Vorapon for coming out, and she has published it. And two great publications shown, one in JAMA, another in Ophthalmology Retina. I think you have come out with great criteria, which are going to help everyone as far as the non-ICG diagnosis of PCV is concerned, because ICG is available with very few people. Even in our country, very few centers will have. And so I think that's a great addition to us, and you have taught all of us, and we'll be also going. Perhaps we should look at her article also in both places much more, as well as she also talked about some kind of a correlations and about the management, how it works, and also came out with certain things, which is the way how they we see in cases of polyps, as well as how they retreat, everything she talked. And also the 50% total complete, she said there is a regression of polyps with aflibercept. I think all that has made us much wiser. And towards the end, Dr. Nishikant Borse talked about the treat and extend. I think this, of course, for me also has been a most favorite way of treating the patients. I think we treated with PRN for a long time, and I think we were doing a little bit of a this thing for patients there because they would lose vision. I think treat and extend is one where, and I'm more impressed. You fished out few studies where in the second year you have shown that they start seeing better, which is in fact very impressive, that with treat and extend you have shown that second year some of these. And also interesting was that Moorefield kind of this thing chart you have shown, that how they go about it. It's also very interesting. So I think treat and extend protocol, not only that it will bring down the number of injections, it is lead to better visual acuity, as well as, of course, the fewer visits are there. So which all problems it can solve. I think it is becoming a way, especially for, I would say, in AMD, this should be the protocol. And we learned a lot, Dr. Nishikant, about it. And Raja had a very, very exciting and very good session, as far as he's always, he'll put very intriguing questions, very practical questions. And the panel, Dr. Mona, always so much of experience of PCV in this country. She is one, has started seeing probably long time back when we were not even recognizing these things. And so is Rupak here from Kolkata. Rupak I have known, he's very passionate and does his work so well. And I think thank you very much, everyone, and especially to Vorapon. And of course, Raja, I think there was a connection problem. You were either going too slow or it was coming as if you were firing like a bullet. So anyway, ultimately it turned out very well. So thank you very much, everybody. And thanks, Bayer, for organizing such an stimulating and useful session on new Astro AMD and PCV. Thank you very much.
Thanks.
Thank you. Bye-bye.
Thank you all.
Thank you all. Bye.
Excellent, excellent.